In the second half, my colleague Gina Hoxie will be providing an in-depth overview of the proposed rule itself. It is estimated, based on the proposed rule, the total impact on hematology oncology is negative 3.9%. Keeping in mind, the actual number will depend on the mix of services. The factors influencing the cuts are as follows. First, a decrease to the conversion factor of negative 2.8%. Secondly, an estimated RVU decrease of negative 0.5% for hematology oncology. And then lastly, the 1.0 work floor is set to expire on December 31st, 2024. The first part of the webinar is focusing on the background of the physician fee schedule payment, specifically how codes are created, valued, and calculated, the types of RVUs that factor into reimbursement, the impact of the conversion factor, scaling adjustments, and RVUs on reimbursement, and lastly, how the conversion factor is calculated. To understand the physician fee schedule and the impact of the proposed rule, we need to go to the very beginning. There are three entities that are involved in reporting and payment: the CPT editorial panel, the RVS update committee, and CMS itself. CPT, or current procedural terminology codes, are created by the AMA CPT editorial panel. This panel ensures that CPT codes are up to date, reflect the latest medical care. Panel is authorized by the American Medical Association to revise, update, or modify CPT codes, descriptors, rules, and guidelines. If a CPT code has been accepted by the panel and is scheduled to be published in the manual, it moves on to the valuation stage. Valuation is the responsibility of the RVS Update Committee, or the RUC. They are tasked with valuing the resources required to provide physician services, specifically physician work and practice expense. The RUC's value recommendations are then submitted to CMS for calculation. And calculation is the final step in this process. CMS uses the RUC's recommendations as a baseline for determining payment rates. However, they also consider public comments, medical literature, comparison to other codes, physician and other professional expertise, and lastly, Medicare claims data. What is a relative value unit, or RVU? An RVU identifies cost components linked to procedures and services described by CPT codes. When you think of RVUs, typically the work RVU is the first thing that comes to mind. However, there are other RVUs, such as practice expense and malpractice, that make up total reimbursement. The physician work RVU is the labor associated with providing a service. It has two components. The first is time, the typical amount of time it takes for a physician to perform the service. Total time of the service is divided into three parts: the pre-service time, the intra-service time, and the post-service time. The second component of the work RVU is the intensity complexity. In other words, the physician effort involved with performing the service. But in order to quantify the intensity, an intra-service work per unit of time is calculated, creating a ratio of RVUs per minute. The practice expense RVU considers two types of practice expense: direct and indirect expenses. Direct practice expenses are comprised of three components. First, clinical staff labor, which is the time spent on clinical activities by clinical staff. Each type of clinical staff, such as an RN, LPN, MTA, or an RN OCN, is assigned a rate per minute, which varies by clinical staff type. The second component is disposable medical supplies used to perform a service, such as gloves, syringes, or an IV infusion set. The last part of a direct practice expense is equipment, and that's the equipment used to perform the service, such as an exam table, medical recliner, or an IV infusion pump. Indirect practice expenses include items such as non-clinical labor, such as the billing staff, receptionist, practice manager, the lease or rent for the office services, office supplies, non-medical equipment, IT, and professional services. And where does the CMS get all this practice information from? Direct practice expense values are determined by recommendations from the AMA-RUC, invoice submissions, and the Bureau of Labor Statistics. Indirect expenses are calculated for oncology using 2003 survey data from Drug Administration Services. The Centers for Medicare and Medicaid Services are currently reevaluating their process and methodology for collecting practice expense data, which I'll go over a little bit later in this presentation. CMS has realized that the PE information may not be the most accurate or up-to-date. In the proposed rule, it was noted they are contracting with RAND to analyze and develop alternative methods for measuring PE and related inputs. In addition, the American Medical Association launched its own physician practice information survey to collect representative data on practice expense and the hours spent in direct patient care. We're going to take a closer look at practice expense using the CPT code 96413 as an example. Clinical labor, like physician work, is divided into three parts: pre-service time, intra-service time, and post-service time. So for 96413, for example, there's 2 minutes of pre-service time, 90 minutes of intra-service time, and 6 minutes of post time. For each minute of work, RN OCNs are assigned a rate of 81 cents per minute in 2025, which reflects the last or year 4 clinical labor pricing update. As mentioned, CMS uses Bureau of Labor and Statistics data as the main source of wage information data, but for any staff types that are not covered by BLS data, CMS uses crosswalks or comparison to other staff types and uses supplementary data sources for verification when possible. Moving to medical supplies. Now, this is a very abbreviated list of supplies for 96413. You can find the full list of supplies in the direct input information that is located on the CMS website. So here we have outlined a few of the supplies. That includes gloves, an IV infusion set, syringe, heparin, and a swab pad for alcohol. For each supply item, the appropriate quantity per service is determined, along with a cost per unit. The RVS Update Committee provides CMS recommendations regarding supply inputs and the quantity for consideration. So in 2017, CMS contracted with an outside consulting firm to update the direct PE inputs for supply and equipment pricing. And CMS did update pricing in 2017 for 2017 supply and equipment items used as direct PE inputs. CMS transitioned those supply and equipment pricing updates over a 4-year phase-in. The RUC continues to encourage CMS to consider all pricing data, including invoices and any other supporting evidence that they have received from specialty societies, during the RUC process. And 2022 was that final year of the 4-year market-based transition for supply and equipment pricing. The last piece is the equipment. For 96413, there are 3 pieces of equipment: an IV infusion pump, a biohazard hood, and a medical recliner. In order to calculate the equipment PE, the following items are factored into the calculation: the equipment costs, the useful life of the particular piece of equipment, and interest rates. Purchase price is determined using invoices and information submitted by specialty societies during the RUC process, other stakeholders, and industry, as mentioned in the previous slide. The useful life for each of these services equipment is 10 years. Then, for each item of equipment is a corresponding number of minutes. An infusion pump and chair is used for 90 minutes per session, while the biohazard hood is used for 20. The minutes per year is calculated assuming continuous usage over the year, about 150,000 minutes. Then also applied to these numbers is an interest rate based on a sliding scale, and that number varies based on whether the useful life is under or over 7 years. And lastly, a maintenance factor is accounted for in the calculation. Now we're going to put all those PE components together to get our PE RVU. When you add up the clinical labor, supplies, and equipment, it gives you the total direct PE costs. In the case of 96413, the total direct PE cost for 2025 is $104.71. This number will be important later when we look at PE RVUs. To calculate the PE RVU, direct costs are adjusted to achieve budget neutrality, then converted into RVU inputs. And what does that mean? Remember that the physician fee schedule is budget neutral, meaning CMS only has a certain amount of money to work with in sort of this pie. So if for that year some services have increases, other services will be subject to decreases to fit within the budget. So using 96413 as an example, a direct scaling adjustment is applied against the actual costs of the equipment, which are listed in the first column, using the 2025 direct scaling adjustment. Now, this is a budget neutrality mechanism to convert the actual cost to an adjusted cost. So you can see here when the scaling adjustment is applied, in this case, this cuts the cost in half. And this is occurring to pay for some of the updates, such as the increase in clinical labor per minute. And then lastly, the costs are converted to create the PE RVUs using the 2024 conversion factor. So when you look at the history of the direct scaling adjustment, the indirect scaling adjustment has maintained a relatively steady rate, while the direct costs have gone down significantly, again, to account for some changes in CMS, whether that be new services or revisions to current services. The next part is indirect costs, because remember, there are 2 parts for practice expense. For each code, direct and indirect practice expense percentages are determined. These percentages vary by the specialty and service. Percentages are calculated by taking a weighted average for the specialties that provide the service. So for many CPT codes, it's not just one specialty that performs the service. Sometimes it's several. So in the case of 96413, the indirect costs are 62% and the direct costs are 38%. Whereas direct PE is calculated simply by adding up the components at the service level, Indirect P cannot be directly attributed to a particular service or services. Indirect costs are items such as rent, non-clinical staff labor, etc. So what CMS does is they create a pool of total indirect PE across all the Medicare physician fee schedule services. And that is allocated using a complex multi-step formula that also takes into account physician work associated with the service and direct costs associated with that service, adjusted by a ratio, which reflects the cost structures of the specialties that tend to bill for the service. The adjusted indirect is calculated by taking the indirect allocator for 96413, in this case 3.32, multiply it by an indirect scaling adjustment, and then multiplying it by the indirect practice cost index, which comes out to be 2.01. And then this brings us to the final step of calculation of the practice expense RVU. The converted direct costs are added to the adjusted indirect cost to determine the PE RVU. Then additional budget neutrality mechanisms or adjustments are applied, which further reduce the values. So in this example, the final PE RVU for 96413 in 2025 is 3.36, which represents a decrease from last year's PE RVU of 3.53. The next RVU component are malpractice RVUs, and those are the relative costs of professional liability insurance, otherwise known as PLI. The malpractice RVU is calculated as follows. First, a national average malpractice premium is calculated for each specialty. Next, a specialty-specific risk factor is created. Then an unadjusted malpractice RVU is calculated based on the volume of practitioners who perform the service. Now here is where, again, budget neutrality comes in. The final RVU is adjusted for budget neutrality, further reducing the costs. Now you put everything together, the physician work RVU, a PE RVU, and malpractice RVU. It would be multiplied by a specific GPCI or geographic practice cost index to come up with the payment rate. The sum of these items is also multiplied by the conversion factor for the total payment rate. In this case, we did the national payment rate for 96413. So for 2025, that will be $119.72, representing a decrease of negative 7.3 from $129.16. The actual rate will vary by state. This is a state-by-state look at the payment rates for 96413. So you can see there's a great variation among the states. The highest looks to be right now California with $139.08. And the lowest here is Arkansas at about $103.15. And you look at the payment rate history for 96413, you'll notice a few things. While there was an increase in 2021 and a slight decrease from 2018 to 2020, there was a significant decrease in 2021. As if you remember, that's when the changes to the office and outpatient E&Ms happened. There was an increase in the payment for those E&Ms, but again, they have to make room in that budget to accommodate those changes. In 2024, CMS did increase the conversion factor from March through December from 120 so you can see where the payment rate went up from $127.05 to $129.16. However, the proposed conversion factor for 2025 will bring it down once again. And you may be wondering how CMS calculates the conversion factor itself. It's a mix of factoring in the current economy, the number of Medicare beneficiaries, the amount of money spent in prior years, and regulation changes. There is also something called the Medicare Economic Index, which is a measure of practice cost inflation to estimate annual changes in physicians' operating costs and establishing appropriate Medicare physician payment updates. However, the influence of the MAI on annual payment rates has significantly decreased over the years. So you can see from this chart from the American Medical Association that there is significant gaps between practice cost inflation and fee schedule updates. And later, Gina will talk about ASCO advocacy efforts in this area. In regards to budget neutrality, scaling adjustments and budget neutrality hold PE RVUs relatively steady each year. Changes in the conversion factors and the associated direct scaling adjustments offset one another. But this is not the case with work RVUs. As work RVUs for services increase or new codes are added with corresponding RVUs, the total number of RVUs in the pot increase. The conversion factor, budget neutrality adjustment, decreases the financial value of all RVUs to accommodate any increases or additions to the pot while staying within the budget. The conversion factor is also impacted by statutory updates, both temporary and permanent. When we look at the history of the Medicare physician fee schedule conversion factors, going back to 2017 and looking ahead to 2025, for a few years it remained relatively steady, but again dropped significantly after 2021. Remembering that everything has to be budget neutral, changes have had to be made to the budget to accommodate either new rates or new services. Examples of that are the add-on complexity code that was implemented in 2024 and the new patient navigation services. And again, as a reminder that in 2024, they did do an increase to the conversion factor from March to December. But looking ahead to 2025, that will go down again to below the 2024 original number. So any questions, just as a reminder, can be submitted through the Zoom Q&A, or if you have any questions post-webinar, that may be sent to practice@asco.org. So with that, I am going to turn it over to my colleague, Gina Hoxie.
Thank you, Allison, and good afternoon, everyone. Let me see here. Oops. Okay. Good afternoon. It is nice to see you all today on this lovely summer afternoon. My name is Gina Hoxie, and I work in ASCO's Policy and Advocacy Department. I'm the Director of Payment and Access in our Regulatory Affairs team. So to follow on what Allison just covered, I'm going to go over the fee schedule proposals for 2025. This is not a total look at the fee schedule. We tried to pull out a few things that are most relevant to cancer care. But if we get to the end and there's something I did not touch on, please feel free to ask. For purposes of time and interest, we tried to really keep it to some of the more relevant provisions for 2025. All right, so to get started, this is not new. Allison just went over this, but it's a point that we need to keep making over and over and over because it's just not sustainable. So for 2025, CMS is proposing a 2.8% decrease to the conversion factor. This is coming from really the end of the funding patch that Congress passed in March of this year that ends at the end of 2024, and there is currently nothing in place. That is where the bulk of this decrease is coming. There's also just a 0% statutory update for this year. There's no automatic increase to the conversion factor. And then there's also a minor budget neutrality adjustment also. So that's why the 2.8% decrease. Every year in the fee schedule, CMS releases what they call a specialty impact table. And this is just to give a sense of what's happening in the fee schedule by specialty. It's meant to be a broad overview. It's not specific. What your actual reimbursement will look like in 2025 is very different based on where you live, as you just saw that map that Allison had, and then also the mix of services that you actually provide in your practice. So for 2025, CMS estimates a 0% change from 24 to 25. We just want you to be aware of this in case you see it in the news, written up inside health policy or anywhere else that comes across. If you see this, what this number actually means, what this reflects is the changes in RVUs and reimbursement from 24 to 25 due to the policy changes in the fee schedule itself. This does not reflect the conversion factor. So this is strictly changes to codes in the fee schedule. We at ASCO also do our own analysis to try to get a better understanding of the impact of on hematology and oncology. And according to our analysis, we estimate a 3.9% decrease in payments for 2025. This includes the conversion factor. That is included in that decrease. It also includes any budget neutrality adjustments, any coding changes, and all the policies that are included in the fee schedule. So what we're looking at next year is actually a 3.9% decrease across the board generally. I know that you've seen this slide, but we're going to keep showing you this because this is what current reimbursement looks like under the fee schedule as it stands now. The slide on the left is your conversion factor. As Allison just went through, it was $36 in 2019 and is falling to $32 in 2025. We are having the exact opposite reimbursement rates compared to any other provider in Medicare. On the right side, I know you've seen this again. This is 96413, your general chemo admin code reimbursement. This is the national reimbursement. This is not what's actually happening at your state. But reimbursement has fallen from $143 just 6 years ago to roughly $120 in 2025. So these decreases are on top of all that administrative burden that you have. There's prior auths, there's EHRs, there's new coding, there's trying to understand all the new rules that CMS is adopting on, HAT, there's AI. I mean, there's just so much happening. So this is on top of all that other stuff that you've got going on and increasing inflation. That's the fee schedule. Just a quick note, I'm not going to talk about the provisions in the quality payment program. Again, if you have any specific questions, please feel free to email me afterwards, but just wanted to touch on how the quality payment program also affects payments in performance year 2025, which actually affects your payments in 2027. So for performance year 2025, CMS is maintaining the MIPS performance threshold at 75. This is the same as it is in 2024. That means if you hit that 75 mark, you have a 0 payment adjustment. If you exceed it, you will have an increase. And if you decrease or if you do not hit the 75, then you will receive a penalty. For performance year 2025, which is reflected in your payments of 2027. So along with this threshold, CMS releases an estimate on what they expect or who they expect will receive the most penalties. So if you look at all MIPS eligible clinicians, every single person that reports MIPS, they expect about 15% of these clinicians to receive a penalty in 2025. It gets worse as you look at solo practitioners and small practices. Those numbers go up. If you're looking at a solo practitioner, it's 46%, and small practices are 21%. So small practices are really bearing the burden of the MIPS penalties. Again, not sustainable, and I don't think that this is what CMS is intending. We just need to protect these practices and everyone else from all these decreases. And then just a quick note on advanced APMs. There is no incentive payment for performance year 2025. That expires, that little bit that Congress allotted for 24, I think it was just under 2%, that expires at the end of this year, and there's currently nothing in place. Okay, so if all of this, everything that Allison just talked about, the continuing to decrease that direct scaler where you're not really being reimbursed for your practice expense, the continuing decrease in the conversion factor, the continuing decrease in actual reimbursement for the services that you provide. If you care at all, just take out your phone and snap this QR code. What this will do is take you directly to our ASCO's ACT network page on physician payment reform. It is absolutely the easiest way for you to get in touch with your lawmakers to tell them that this is not sustainable, that this isn't working, that practices are underwater because of these continuing decreases. What you do when you go in here, you can just fill out a few boxes of your information, and there are pre-drafted letters that will get sent to your lawmakers from you. You can personalize them, but the language is already there. So all you have to do is fill in the information, and that information will get sent to your lawmakers. Currently, what we are asking for is an automatic inflationary update. We know that inflation is rising and rising and rising, and practices should get an inflationary update also. Eliminate budget neutrality so that there isn't a pie that's we're constantly shifting things around, but so that there is some extra money to incorporate new services, to make meaningful changes to MIPS, and then to incentivize the transition to value-based care. I really urge you to go on the ACT network and look at this. Like I said, it's super simple. And we have alerts not just for physician reimbursement, but there are other cancer care priorities up on our website also. Just a couple of examples are drug shortages, and then also telehealth. Telehealth is another big issue in the fee schedule. Okay, so telehealth in 2025. Right now, as everything currently stands, all of the COVID flexibilities that were in place regarding telehealth will expire at the end of 2024. And when I say all, what I really mean is the originating site and the geographic restrictions. So right now, while those flexibilities are in place, any Medicare beneficiary can receive telehealth regardless of where they are located. If it's a rural site, if it's a city, it doesn't matter. And they can also receive telehealth at home. They do not have to travel to an originating site. So that is only in place as of right now through the end of 2024. Beginning January 1, all those flexibilities will go away unless Congress acts. They have a few months to get this done before the end of 24, and I think we're optimistic, but again, we can't be sure until legislation is actually passed. So in order for that to happen, Congress needs to pass legislation. Okay, so let's put aside the originating site and the rural piece aside. There are some things that CMS does have authority over, and they did make a few changes that will go into effect in 2025. The first one is audio only. They are going to permanently cover audio only services when a patient is at home. And that is any service that is listed on the Medicare telehealth services list. So if a patient is at home, they will permanently cover audio only. Again, the caveat to that, though, is that Congress has to waive that originating site facility restriction so that a patient can be at home to receive telehealth. But it is good news. The second thing is a practitioner home address. So a couple of years ago, CMS released, it wasn't guidance necessarily, but it was a communication saying that they wanted clinicians to report their home address on their Medicare enrollment forms if they were providing telehealth services to Medicare beneficiaries at their home. We received a lot of concern from our members on this, and did a lot of communicating with CMS about this, that there were privacy concerns, and we just did not feel that this was appropriate. CMS has extended this, so you do not have to report your home address through 2025. And we will keep working on that so that it goes beyond 2025. And then the last bit on telehealth is CMS is continuing the public health emergency flexibilities regarding direct supervision, so that that is temporarily extended through the end of 2025. They did make a couple of changes permanently in two situations specifically. The first one is for your level 1 outpatient E&M, the 99-11. That you can use audio-visual technology for direct supervision permanently. That is not temporary. And also for any code that has a PC-TC indicator of 5, which indicates that it is primarily done by auxiliary personnel. So something like a 96413, your chemo admin, again, you can do direct supervision permanently with that. All right, moving on to a few coding updates in this year's proposed rule. So during last year's CPT and RUC editorial panel cycle, as Allison was describing, the RUC and the CPT adopted billing and coding for CAR T services. Those then go to CMS, and CMS has adopted the 4 codes. They are for the harvesting and preparation of T cells, and then the receipt and preparation and actual administration of the CAR T cells. CMS has accepted the RUC recommended work RVUs for the 4 codes, which you can see up here on the screen. They did not, however, adopt the PE RVUs, those practice expense RVUs. So the clinical labor, the equipment, and the supplies, that is yet to be determined, except for the CAR T cell administration code. This last one, the 3X021, CMS is accepting the RUC recommended PE of 5.28. CMS is accepting comments on the other 3 PE RVUs right here. So again, clinical labor, supplies, and equipment that go into those services. But they are accepting these codes and will reimburse them under the fee schedule in 2025 if they finalize their proposal as proposed. Okay, so last year CMS finalized a new code. This is a Medicare only code, a G code, G2211. There was a lot of discussion around this code last year, as it was really responsible for that drastic budget neutrality adjustment and the decrease in the conversion factor. CMS is not making any changes to this code from last year. So this is still billed with an office or outpatient E&M for a new or established patient. So it's billed with a 99202 through 215. And again, CMS, this is to capture the relationship between the physician and the patient, which CMS does not believe is captured in any other coding. And then last year, they also finalized that you cannot bill G2211 with the base E&M and another service that would require a modifier 25 on the same day. So this was all finalized last year, and there are no changes to this first set right here. There's a minor change to the modifier 25. So they're expanding the use of G2211 in 2025. if you have a patient that comes in for an annual wellness visit or another preventive service, then they end up having an evaluation and a management service on that same day, and you would bill the G2211, that would require a modifier 25, and CMS is saying that that is fine. That for an annual wellness visit or another preventative service or vaccine administration, you can bill G2211 with your E&M code, even though there is a modifier 25. Just want to be clear, there are no changes in the things that CMS finalized last year. They're only expanding the use. They are in no way diminishing its use. A couple things on telemedicine codes. CMS is adopting the AMA virtual check-in code 9X091. This is a patient-initiated virtual check-in service. It would be done by an established patient, and it would most likely be an email, or they would snap a picture of something and send it to you. Just to check in on something small. This does not require AV technology. It's not a telehealth service. It wouldn't follow an E&M. So if somebody had an E&M that was less than 7 days ago, you would not bill this. And if it leads to an E&M within the next 24 hours, again, you would not bill this. It's separate from any immediate evaluation and management service. And this is to replace the CMS only code G2012. It's essentially the same thing. They are just taking the actual AMA CPT code instead. And there is a work RVU of 0.3. Also in last year's CPT and RUC cycle, the AMA put forward 16 new telemedicine codes. They are evaluation and management services that are done through telehealth. They went through the AMA, the CPT, and the RUC process, and then they went to CMS, and CMS is choosing not to reimburse these specific codes. They are giving them a status indicator I, which means that they are inactive, but other private payers could use them. They're just not reimbursable under Medicare. CMS's rationale for this is that there are existing codes that already do this exact same service, and that would be the existing office and outpatient E&M services that are on the Medicare telehealth services list. So in CMS's mind, I think they just thought that those 16 new telehealth codes would be duplicative and essentially the same thing as what they have on the Medicare telehealth services list. So they will not cover those in 2025. All right, moving on. Last year, you will remember that CMS adopted 5 new codes to address health equity. These are Medicare-only codes. They all start with a G, and these were for principal illness navigation, community health integration, and the social determinants of health risk assessment codes. These were all new last year. They are not changing anything to do with the codes for 2025. If you're billing them, you will continue to bill them as you are. There's nothing new about them in 2025. CMS is, however, requesting information from stakeholders. There's a few specific, I think they're open to really hearing anything, but there are a few specific things that they call out in the rule. They would like to know if there's any changes or updates that practitioners think should take place within the code description, if there's activities that should be included in those services. They also want to know about the personnel and the training requirements. I think training has been somewhat of a sticking point. The practices would like more information about what this means and what's required of them. I think the other thing that they're interested in is any barriers to actually implementing these codes. I think that while we don't yet have data on them, as we are still in the first year of their use, I think anecdotally, there's a lot of discussion around a slow uptake of these codes, both for navigation, health integration, and the risk assessment. And I think CMS wants to encourage their use, but they need to understand what the barriers are also. So if you are a practice that happens to be implementing these and would like to share with CMS, that would be great. They are accepting comments through September 9th. If you would like to share them with me, I am also happy to potentially incorporate them into our comments to the agency. But again, no changes, just CMS looking for information. And then lastly, this is just a few updates, policy updates that are also included in the proposed rule. CMS is making some coverage and reimbursement changes to colorectal cancer screening. They are removing coverage for barium enema, and they are adding on coverage for the computed tomography colonography. This is to align with both current clinical guidelines as well as recommendations from the United States Preventive Services Task Force. The other thing that CMS is doing is they are going to consider a colonoscopy after a Medicare beneficiary takes a blood-based biomarker test. If that comes back positive, then CMS will cover the colonoscopy as a preventive service, not a diagnostic service. Therefore, there will be no cost sharing. They did make a change to that a couple of years ago, but it was just for the home-based stool test. So now this year they're adding on the blood-based biomarker test also. A couple notes on dental services. They are continuing to expand coverage of dental services. Last year, they finalized a proposal to cover dental services for cancer patients before and during chemotherapy and CAR-T. They are also covering dental services for Medicare cancer patients that are receiving bone modifying agents, as well as those that have head and neck cancers. There are no additions specifically for cancer patients in the 2025 rule, but they are considering, or they are continuing to consider adding on more coverage. So that's something we can always keep in mind if there are other clinical situations that would require a dental service in addition to the medical service. And then finally, CMS is going to make a couple changes for preventive services. Again, this is not specific to cancer, but always something to keep an eye on because who knows what it will lead to in the future. CMS is going to cover a hepatitis B vaccine for anyone that has never had it, or if they have no record of having it. And then also for the first time, CMS will cover a drug, the PrEP drug, as a preventive service, which means there is no cost sharing to the beneficiary, and that's PrEP. That's for the prevention of HIV. So that is everything I have on the fee schedule. Like I said, I did not cover everything. There's a lot more in there, but I think that if you have questions on anything, we're happy to answer them. Anything for me, anything for Allison, and I'll stop there and hand it back to Allison.
Hey, there does not appear to be any questions in the chat right now. As Gina mentioned, you can send any questions to practice@asco.org if you think of anything later. Okay. Well, with that, we're going to end the webinar. So thank you very much, everybody. A recording will be available at a later time. And again, please send us questions if you have any. Thank you very much and have a great day.